Hello and welcome to all who are joining us on Facebook Live at WBLS 1075 NYC and our YouTube pages. Welcome. I am Shaila Scott, radio personality for 107.5 WBLS. And today we're going to delve into Black maternal health matters. Why? Because Black women are 2 to 3 times more likely than white women to die in childbirth. 60% of those deaths could have been prevented, and Black women are dying in hospital beds where they should be appropriately cared for. We're about to bring some awareness to some shocking statistics, addressing the root causes and what our super sheroes who I have with me today are specifically doing to reduce the disparities. Thanks to the New York City Department of Health for being our ally in the birth and reproductive justice movement. And we are calling for accountability, birth justice, and anti-racist care. I have with me today influential Black women in positions of reform around mental health in New York City. And I encourage you to reach out to any women who are at risk, who may benefit from the resources that we're going to share with you today, and share this video with anyone who you feel may benefit from this information as well. And I will introduce my esteemed guests. They will take 2 minutes to tell who they are and what their role is as it pertains to maternal health. We'll start with Dr. Ashanda Saint Jean. Welcome, Doctor.
Thank you so much for having me. My name is Ashanda Saint Jean. I'm a board certified attending physician in obstetrics and gynecology. I have worked over 20 years in New York City serving minority, underserved, underrepresented women in the boroughs of both Queens and Manhattan. I'm currently the chair of OBGYN at Health Alliance Hospitals, part of the Westchester Medical Center Health Network, but also I am a consultant for the New York City Department of Health. I'm a physician, part of the Birth Justice Defenders, and also I'm the Diversity, Equity, and Inclusion Excellence Advisor for ACOG, which is the American College of Obstetrics and Gynecologists, District 2, which represents New York State. So thank you so much for having me.
Oh, thank you for being here. Next, we're going to turn to my next guest, Dr. Amita Murthy. Welcome, Doctor.
Thank you so much for having me. I'm so excited to be here. My name is Amita Murthy, and I too am a board certified obstetrician gynecologist. I currently work for the New York City Department of Health as the clinical lead for our Maternity Hospital Quality Improvement Network. This is a program that's designed to attack many of the factors that are leading to the scourge of maternal mortality and morbidity in our Black and brown women. I have worked also for the underserved as part of the staff of a number of different hospitals within the New York City Health and Hospitals Corporation, mainly in the Bronx and in Manhattan. That was before my transition here to the New York City Department of Health. And I am really excited to be here. Thanks.
Ooh, we are excited to have you. Trust and believe. Please welcome our next guest, Folake Eniola. Welcome, Miss Eniola. How are you?
I'm fine. Thank you, Shaila. And I am also very excited to be with you today. My name again is Folake Eniola, and I'm currently the Senior Evaluator of the Maternity Hospitals Quality Improvement Network Project. I oversee the evaluation of this initiative that bridges clinical and community and public health sectors to reduce severe maternal morbidity and maternal mortality across 14 hospitals and their surrounding communities. In addition to my work as an evaluator with this initiative, I support various maternal health equity projects within the New York City Health Department. I also support the Health Department's Maternal Morbidity and Mortality Review Committee and Severe Maternal Morbidity Project, where I worked on a study that elevated the voices of women who experience severe maternal morbidities. Prior to that, I also worked at the Center for Health Equity as a research director, actually in Harlem, where I oversaw some of the place-based initiatives, evaluating those initiatives in Harlem. And I'm happy to join the panel today.
Thank you and welcome. And our final super shero is Annalee Reid. Hello, Annalee.
Hi, everyone. So glad to be with you all today. I'm Annalee Reid. I'm a community midwife. I live and work in Bed-Stuy in Brooklyn. And basically, since 2017, I've been working in my little corner to figure out how to address the needs of laboring persons in regards to maternal mortality and Black maternal health. I've worked with high school students, middle school students, doing career days and educating around sexual reproductive justice, doing Black maternity health education in community baby showers throughout the New York City area. I sit on my community board, shout out to Community Board 3, and really pushing civic engagement at all, areas of activism. I also have been recently appointed co-chair for New York City Midwives, which is a local chapter for our professional organization, ACNM, and I'm really happy to be here with all of you today. And in addition to my work with Brooklyn Birth Justice Defenders, so really happy to be here.
Well, thank you for being a part of our Justice League. So we're going to kick off the panel discussion. First, I want to mention something that I read years ago, maybe almost 20 years ago. Maternal death rate from hemorrhage was more than 4 times the national average. I would like to ask each and every one of you, what would you say is the current state of Black maternal health here in New York City and even nationwide? We'll start with Dr. Ashanda Saint Jean.
Yes, so I think that, before we delve into specifically what's happening in New York City, we first must look at our nation and kind of look at what is the data that shows us what our pregnancy-related mortality in the United States. So the CDC data that we received in 1987, 7.2 maternal deaths occurred per 100,000 people. That number skyrocketed in 2017 to 17.3 maternal deaths per 100,000 people. Now, if we further dissect and explore this pregnancy-related mortality by race and ethnicity, non-Hispanic Black women have 41.7 deaths per 100,000 in the United States. When we compare that to their white female counterparts, their number is only 13.4. And for Hispanic women, it's 11.6. So therefore, Black women have a greater than 3 times risk of pregnancy mortality. And that is quite a stunning number. Now, if we look at New York State as a whole, New York State ranks 23rd in the nation for maternal mortality. And 51.5% of those deaths occur in Black non-Hispanic women. White non-Hispanic women account for 30.3% of deaths, 12.1% is for Hispanic women, and 6.1% for non-Hispanic women. Now, when we look at that number, it is an astounding number. But if we also take into account that Black non-Hispanic women only represent 15% of live births in New York State, but also represent 51.5% of deaths, that is truly, truly an astounding number. So Black non-Hispanic women for New York State are 5 times more likely to die in a pregnancy-related cause. And this is an overwhelming difference when we look at kind of the racial disparities that exist. So we have to take this number into account and have to have a public action plan because this is a public health crisis. My colleague Folake is going to further dissect those numbers as we apply them to New York City as a whole.
Yeah, can you dissect those numbers, Folake?
Yeah, sure, Shaila. So thank you, Dr. Ashanda, for laying that groundwork. Here in New York City, each year there are approximately 120,000 births, right? And out of these births, we lose approximately 25 to 30 mothers to a pregnancy-related death in New York City. This is considered the death of a mother that occurs during pregnancy or within a year from the end of the pregnancy. And Black mothers, unfortunately, experience a disproportionate burden of those maternal deaths. So as Dr. Ashanda said, while Black non-Latino women make up 20% of live births in New York City, we make up 54% of maternal deaths. And this is compared to white women who make up 33% of live births and 11% of maternal deaths. In fact, our data show that Black Black women in New York City are 8 times more likely to die from a pregnancy-related cause than white women. And for every woman that dies, hundreds more almost die due to severe maternal morbidities. And these are what we call SMMs. These SMMs are life-threatening complications in childbirths, and they're about 100 times more common than maternal deaths and largely preventable. So in New York City, when we look at these SMMs, approximately 2,800 mothers each year suffer a near-death experience from the SMMs during childbirth. And these include things such as heavy bleeding, kidney failure, blood clots, strokes, or heart attacks. Our data similarly show that the experiences and outcomes of Black women are vastly different when we compare to mothers of other races and ethnicities. So when Black women experience a serious complication during birth, they do so at a rate that is 3 times that of white mothers. The data also show us that, education and socioeconomic status, which are often protective with regards to health outcomes, are not protective for Black mothers. So we see that Black mothers with a college degree or with, high SES have higher rates of severe maternal complications than mothers of any race or ethnicity who have not graduated from high school. And we can, look at this when we hear of stories from Serena Williams, Beyonce, and even the CDC epidemiologist, Sharon Irvin, who passed away from pregnancy-related causes. So the data that we see really support what we know to be a driving force right behind these inequities in maternal outcomes. And we'll talk more about that. So Shaila, to address your question, yeah, we are in an urgent state with regards to Black maternal health in the United States. And there's an urgent need for us to address the root causes of these unacceptable and inequitable outcomes for Black women.
Right. Annalee, from your angle, what would you say is the current state of Black maternal health?
On the community level, we're seeing that women are terrified, right? They're terrified to become pregnant. They're terrified to have their babies. They're terrified walking into hospital doors. We have families that are grieving the loss of a mother, a partner, a neighbor, a best friend. And all of these things are impacting our community on large scale levels. Just last week in one of our Brooklyn Justice Defender meetings, we had a member that was expressing to us concern about a family member who was in labor, and she was possibly going to be given a C-section because of whatever reasons, and she was scared. She was very terrified for her family member, and so in real time, we worked to try to get her a doula, present her with the options that were available to her family member, for her to ask her providers and get clarity and at least be a part of the process. But this is something that we're seeing over and over and over again all the time. We're having a lot more discussions around out-of-hospital birthing options as well, which thankfully to COVID, I guess you can say, has been something that's opened up as an option for more people. And that has been a source of, I guess, peace for many families. But just a lot more activism is being seen as we're also dealing with, these Black birthing families that are grieving losses of family members and or having complications or morbidities throughout their pregnancies or throughout their, postpartum period, on top of the racial state of this country, right? So our families are dealing with this, and that's like compounding medical conditions on top of social, on top of, it's a lot. Yeah. That's what we're dealing with in the community, trying to figure out how to maneuver that.
It's quite daunting, and COVID definitely adds to it. Dr. Murthy, what can you add to this as far as the current state of Black maternal health?
I have to agree with all of the ladies beforehand with their comments. I think the one thing that is challenging is, and that actually has been a wake-up call with COVID, has been just a highlighting of disparities in general.
Yeah.
And I think that despite the fact that New York City has had a crisis in maternal mortality for a number of years, it really hasn't been until now with COVID that we're seeing all of the disparities in general. And it's just highlighted what we're seeing with Black moms and brown moms.
Wow. I want to stay there for a second on COVID. Dr. Ashanda, maybe you can answer this question. How has the COVID pandemic specifically impacted Black females, in particular, expecting mothers and mothers of young children?
Right. So first, like we have to, when we kind of unravel the layers of COVID, right? We have to talk about the beginning, the onset of COVID during the pandemic, and to what our present state is now. So initially, when COVID first occurred, I was working in Upper Manhattan. We were very hard hit by COVID, and what was happening was a lot of the clinics and offices just closed. And so a lot of patients at that time had a big fear of the hospital experience or getting COVID in the hospital. A lot of people were staying home. A lot of their healthcare was elevated to a telemedicine platform. So you found that there was a lot of poor compliance with prenatal care. There were a lot of missed appointments or appointments that were canceled. They were less likely to report adverse pregnancy symptoms, and there also was a decrease in trust. And many patients, especially patients of color, were exploring the opportunities of home births because they just didn't want to be in the hospital. And there was also the heightened risk of the severe symptoms of COVID. There was increased maternal health mental issues of anxiety and depression. There was increased domestic violence. There was a strain in the healthcare infrastructure. And also women were most likely to lose their income during the pandemic because of loss of employment. And then there was also struggles that working mothers had to endure with the increase of childcare demands and also homeschooling. So I think that when we look at COVID, we have to look at the multiple layers in terms of healthcare access, healthcare equity, the elevation to a telemedicine platform where sometimes people don't have smart devices or Wi-Fi. Right. So there were so many different ways that COVID impacted social determinants of health that already impact healthcare as a whole for women of color. So I think that it's very important to understand that what Dr. Murthy had said is that this COVID pandemic, the civil unrest in the country just elevated this as more of a healthcare crisis for us all to address and that we could not no longer avoid.
And speaking of healthcare access and resources, Ms. Eniola, can you help our audience pretty much understand what the Bureau of Maternal, Infant, and Reproductive Health at the New York City Department of Health does, and how our audience can tap into those resources from your agency?
Yes, thanks for that question, Shaila. I think the health department has really committed to improving access to maternal health for mothers in New York City, especially underserved mothers. For example, in 2015, the health department worked with community advocates to develop New York City standards for respectful care at birth. These standards cover six key areas of respect and dignity that list human rights for respectful, safe, and quality maternity care. So they were developed by the health department and are currently being implemented across 14 hospitals and in highly impacted communities across New York City. So our goal with the standards is to ensure that Black and brown mothers in New York City are familiar with them, and it supports and empowers them to advocate for higher quality and respectful maternity care. We also strive to center the voices and lived experiences of Black and brown pregnant and parenting people in New York City. And we're going to talk more about the Maternity Hospital Quality Improvement Network and how we use that as a way to improve access to reproductive health in in communities.
Thank you, Ms. Eniola, for talking about tapping into resources. That's so very important. I know, Dr. Murthy, you've done so much work on identifying severe maternal distress. I want to know, what have you discovered in your work that can provide us a sense of hope?
I think that there is a number of things that we have found in that our maternity hospital quality improvement network really has focused on two key aspects in trying to fight against maternal morbidity and mortality. And I'm going to broadly define them as clinical aspects versus community engagement and respect aspects. And so our clinical, so there's two factors that we see in that, there is the clinical portion of improving clinical delivery of care. We work on changing protocols and changing policies, some re-education and some updating based on data that comes through from various sources. We also focused a little on simulation and using simulation to help prepare doctors for those situations that they don't see that often. Pregnancy is a young woman's wheelhouse, right? And so most young women, almost all young women, are pretty healthy. So many obstetricians don't see those really rare life-threatening situations. And so simulation actually helps people be prepared for those situations that may occur. On the other side of this, we are focusing on, as Folake mentioned, the New York City standards to increase and elevate the voices of our Black and Brown patients, and to ensure that that they're actually heard. Because what we're seeing is that the patients are not actually heard by their clinicians. And so we want to be sure that those voices are heard and that their concerns are elevated and actually attended to. In addition to that, we are also looking at ensuring that the hospitals turn outward, right? We want to turn their focus outward and then be sure that they are engaging in the communities that they live in. That's right. And so making sure that they are aware that there are advisory boards and that there are groups that are willing to work with them to ensure that the community is a part of any actions that the hospitals are working on. So that's including elevating the voices of their community doula providers, in addition to working with community midwives, and really encouraging other avenues for patients to find care that they are comfortable with receiving. So in the case, as we talked a little bit about earlier with COVID, looking for those alternatives, they were really hard to find. Why? Because a lot of them didn't exist. Why? Because the hospitals didn't provide that. And so part of the work of the MHQIN is to ensure that the community is able to go to the hospitals and work with them to elevate those needs and concerns, and hopefully work together to find avenues to get the care that Black and Brown women want.
Yeah, Ms. Eniola, you work to improve strategies for reducing disparities in maternal health outcomes. What have you found are the most important factors in reducing disparities?
Thanks for that question, Shaila. There are multiple factors that impact the health outcomes of Black mothers in New York City. And the disparities that we mentioned earlier are results of diverse factors, right? From the quality of the clinical care that women receive, to access to education, maternal health services, to systemic racism and implicit bias. So each of these have a role to play in the wide and persistent racial gap that exists in maternal health. So our strategies at the health department are really multifaceted and comprehensive, as Dr. Murthy said. We utilize these clinical and community level strategies to improve maternal health outcomes. Some of the more impactful strategies have included developing a system to collect data on severe maternal events at the hospital level, and using that data to inform hospital quality improvement activities. We support the maternal emergency simulation trainings that Dr. Murthy was talking about. We have birth justice, trauma-informed care, and implicit bias trainings that providers receive, and that aim to foster better and more open communication between the patient and the provider, and better interactions around their medical needs. And then we also have these community-centered education and outreach programs, including the Birth Justice Defenders work, which Annalee is a part of, which help to create access and demand for more equitable and respectful care in the communities most impacted by this crisis.
Yeah, and we see you too are multifaceted with being a mom of a puppy and so many things in the background that, you know, we are grateful that we can multitask as women. We always have had to do so, and we do so oh so very well. Welcome, Annalee. Annalee, you know, I wanted to talk to you about some of the ways you see community health workers being used to address the issues facing Black birthing families. But I also wanted to address first you being the CEO of Super Mama Birth and Tribal Mamas, and talking about what you as a health provider in the community setting, what are some of the things you've done in your private practice? So maybe you can address that first, and then we can talk about the community next.
As a private practitioner in the community, a lot of my work is very specific to the community that I've placed myself in, which is in the community in Brooklyn. I work throughout the city as well, but it's really important for me to be able to spend time with my clients. In each visit, we spend about an hour in our visits, and more than half of that time we spend talking, connecting, you know, really understanding what's going on in the life of that birthing person and their family. You know, what's new every time my clients come in the office. What's new? What's going on? You know, is there any way that I can support you extra as your provider? I'm really intentional about the nutritional needs of my clients, and coming from a Jamaican household, also making sure that when we talk about nutrition, we're doing it from a culturally appropriate space, right? So we do diet diaries every trimester and more if necessary, and my clients go through 3 days and tell me everything they've eaten and drunk, and we make sure they're having enough water. How can we get you more? Do I need to, you know, to sign you up for WIC? What are the things that you need to make sure that these complications that are popping up in our Black birthing families do not pass by your door? We build a lot of trust in our relationship, and also one of the interventions that I had put together myself in my master's program is called Calming the Water Session, and that is a mandatory each trimester that each of my clients do. And in the Calming the Water Session, we're addressing specifically what's been happening in your world in terms of microaggressions as Black birthing person. Is it that you were followed in the store the other day? Was your son, you know, stopped by the police because they were driving a Lexus or, you know, a Benz, or you know, what's been happening? And we figure out ways to decompress all of those things, and to make sure that the body does not internalize it in a way that brings up that cortisol response that then, you know, translates into inflammation and all the things that are the sequelae of these cortisol stress responses that we understand are also contributing to maternal morbidity in the Black community. And so that's something that we do specifically in my practice. And then, you know, in working with birth justice defenders and other community health workers, getting out those standards of care, you know, spending time. We go to the community fairs, we go to the Atlantic Avenue whenever they're having street fairs. We go to all of the food fairs, and we have booths that we set up, and we're, you know, doing surveys. We're engaging with the community so that they understand that these standards of care are something that's there and that they should be aware of, and that they can bring to their provider if they're not in a space where they feel like they are being respected in their process.
I am in awe of all of you. You know, you are truly superheroes in my eyes. But, you know, self-care is important as well. Dr. Ashanda I wanted to know if, as a woman of color, how has this affected you with patients and students day to day, seeing some of these things firsthand as an OBGYN and as a woman of color, a professor as well?
Mm-hmm. I must start from the beginning. And I am one of 6 children born and raised in New York City, whose mother received prenatal care through a New York City clinic and became a doctor to help others, but specifically to treat people how I wished my doctors treated me or that of my mother. As a woman of color, I have a responsibility to impact one's life with positivity, love, and understanding. As a child, my parents repeatedly always quoted to me from Maya Angelou, bringing the gifts that my ancestors gave, I am the hope and the dream of the slave. That was embedded in my spirit. I was told each day since the start of my career to lay the healing hands on my patients from my mother. As a physician, I understand the responsibility to serve my patients and provide judgment-free care that is layered with empathy and compassion, and also fully acknowledging the social determinants of health that may impact healthcare access and overall equitable care. It is that passion that I teach residents and medical students who are the next generation of doctors to help one's journey in life to be culturally competent and sensitive to the needs of their patients, to listen and be generous of time, attention, and spirit. So these are the philosophies that are rooted in the foundation of how I work and how I take care of patients. And I have to say, one of the hardest things for me being a clinician is when I have a patient of color who says to me, I don't want to die having this baby because I'm Black. That is heartbreaking to me in 2021, that I have someone thinking that we in New York City, in the United States, that they think they may die having this baby. So, my life's work is to see how I can affect change for women that look like me, but for all people as well. But specifically to address these healthcare and racial disparities that exist in maternal health. Because when I'm on one of the maternal review boards for New York State, and when we examine these cases, it's heartbreaking because some of them are so preventable.
Yeah.
And you are disrupting a whole family, and this fracture in a family is so devastating and traumatic. So I feel that I must affect change in what I do and offer compassion and teach my residents and my medical students that they must affect change and that we must change this racial disparity that exists because it's fracturing families.
Yeah. What does the future of all this important work that everybody is doing looks like for the city of New York within the Department of Health, Dr. Murthy?
I think the future's bright. I mean, we are in a really difficult space right now, I think, with the pandemic from COVID, the crisis that we're seeing with maternal mortality. But I think the fact that we're able to shine a light on this, the fact that everyone that we've worked with has been responsive and willing to work with us and willing to turn the camera lens onto themselves to look at these factors, to actually examine themselves, their hospitals, their ways of working. It just tells me that we are headed in the right direction. I think the efforts on all of our parts with the attending physicians, I think the fact that medical schools are looking at the inherent racism that's built within the medical system, I think the fact that the 1619 Project and critical race theory and education just in general is looking at not only the ubiquitousness of racism, but the fact that it's baked into our system from the bottom up. I think this is all good. It just means that we're headed in the right direction. We are really working very hard to ensure that disparities do not exist any longer.
Well, I think as we get ready to wrap, I would like for each one of you to just give maybe a call to action. Tell what the community can do, what we can do if we see somebody that is at risk. I'm going to start with Annalee. If you can tell me, in your brief closing remark, what you think the call of action is.
Sure. If you're feeling frustrated, if you're feeling helpless, if you're scared of what might be being a birthing person, do your research when you're searching for your provider. Know that there are options for you. If you don't feel seen, if you don't feel heard, you have the right to change your provider, right? Get your hands on these standards of respectful care at birth and follow them. It's written in a way for you to be able to easily express, go through the steps and see what is applicable to each situation that you're going through, and bring that with you to your provider's office. And be intentional. Be intentional. That's like my favorite word. When you're, as a provider, when you're caring for Black working persons, make sure that you're paying attention to the social, the emotional, as well as the medical piece, because all of those things fit together. That is my call to action for you.
Okay, Dr. Ashanda.
So I think that my call to action is listening to the voice of your patients, and also kind of reimagining how we can restructure the foundation of maternal health and see how we can more seamlessly incorporate midwifery and doula care into our maternal health care and provide a holistic approach to our patients. Make sure that this care is rooted in respect and empathy and compassion, and make sure that we have involvement of community-based organizations. And like Annalee said, empower our patients for self-advocacy, and also focus on mental wellness and self-care. And also kind of look at a comprehensive approach that looks at the biocycle and social of our patients, and see how we can affect change by making our patients feel good and feel confident in the care that they receive.
How do we make change, Ms. Eniola?
Yeah, thanks, Shaila. At first, I have to say that this has been a very exciting panel to be a part of, just because we're all using our voices and expertise to protect and care for Black and Brown women. I know that this is a part of a celebration of mothers for Mother's Day, but to truly celebrate all mothers, and especially Black mothers, we have to understand that we really do have a reproductive and birth justice issue right here in the U.S. We know the driving forces behind these disparities. We know that it involves systemic racism, including residential segregation, underinvestment, disinvestment in neighborhoods where the majority of residents are people of color, and inequitable distribution of resources, which all lead to chronic stress and disease, and result in the complications that we see. So instead of simply naming race as a risk factor for poor maternal outcomes, or blaming individuals for not engaging in health promoting behavior, we have to look at what else we can do, right? So to ensure that Mother's Day remains a day of celebration and joy, and a day that we honor women, we have to prioritize Black maternal health. We have to continue to educate, advocate, and elevate using data and using stories, and make sure that Black women, both in the U.S. and abroad, are able to have safe, high quality, and respectful birthing experiences.
You want to bring it on home, Dr. Murthy?
Absolutely. Thanks again, Shaila. I mean, I think we're all saying the same thing. And I think what we're saying is be aware, be intentional, and that there are actions that we can all take to work on preventing maternal morbidity and mortality, but it does not have to be in the role of healthcare. If you feel strongly about the place that you live and the investment in your community, work there, work with your community boards, write letters to your senators, write letters to your representatives, work with your city council. There are other things and other places where we can be aware of actions that may have downstream effects that can help decrease these disparities. It is not just in healthcare that work can be done, but it can be done everywhere and in places that you least expect. So really it's about being aware of those opportunities, being aware of your rights, and being aware of all of the change that you can make for yourself, even if it's not directly in the realm of reproductive health.
Yeah, be intentional, as Annalee Reid says. And Dr. Amita Murthy, Folake Eniola, and Dr. Ashanda Saint Jean, it's been a pleasure to talk to you today and what I deem the New York City Department of Health Reproductive Justice League. You are a phenomenal woman in your own right. And we need more women like you who are watching to join the fight. As Dr. Murthy said, it's safe to say that the neglect of Black women in hospitals and the examination rooms is a form of racially motivated violence. But we've also heard the work that they're putting in to reduce the disparities. And we've heard some solutions as well. The New York City Department of Health has the resources. So I need you to tap into those and share them with someone who may benefit from them, somebody who's expecting, maybe someone who's thinking about having a baby, because you can never be too over prepared for a milestone event like bringing a child into the world. Arm yourself and arm your loved ones with the knowledge. Thank you to our panelists. Thank you to the New York City Department of Health, and thank you for watching. I'm Shaila, and on behalf of WBLS, thank you for being a part of our family.
Thank you.